Hello and good evening, everyone. Welcome to our 21st Blurs Virtual Seminar. Blurs Virtual Seminar is a platform that allows health professionals to discuss current management updates of different health-related topics for better patient care. And this platform is brought to you by Blue Health Ethiopia, a medical consultancy company founded by medical doctors and a computer engineer. And we aim to be an influential healthcare leader in creating a skilled community through easily accessible knowledge in preventive medicine. And as always, I am your host, Adam Getachew. I am the co-founder and CTO at Blue Health Ethiopia. And we are honored to have Dr. Michael Shawel here with us. Dr. Michael Shawel is an assistant professor of clinical oncology and currently working at Harar University, Harar, Hiyot Fana Hospital. And he is going to give us the presentation of breast cancer screening, the concept of breast cancer screening. I think I've taken quite a few time. Dr. Michael, the stage is yours.
Okay, good evening, everyone. Thank you, Adamu. So today I'll be presenting about the concept of breast cancer screening. My name is Dr. Michael Shawel, and I am an assistant professor of clinical oncology, and I'm currently working at Haramain University, Harar. And you can see our linear radiotherapy machine besides me. This is my photo. Okay, so this is the next slide. So this is just to make you laugh. So it can be interactive. So this is a woman after having a mammography. And yes, I did have my mammography today, she said. And why do you ask? So the person was asking her whether she was having a mammography or not. So as you can see from the picture, the plates of the mammography had some effect on her breasts. So the disclaimers of mine are, I don't have any disclaimers and no outlines for the presentation since it's a simple topic. So what's screening? So screening refers to the use of simple tests across a healthy population to identify those individuals who have a disease but do not have yet the manifestation. So usually a screening program should be undertaken only when their effectiveness has been demonstrated and when resources like personnel, equipment, etc. are sufficient to cover nearly all of the target group, when facilities exist for confirming diagnosis and for treatment, and also for follow-up of those with abnormal results, and when the prevalence of the disease is high enough to justify the efforts and the costs of the screening. So even when implemented properly, the screening programs are associated with undesirable effects, which include falsely positive screening tests that results in additional testing, and also the falsely negative screening tests that provides false reassurance and can result in delayed presentation, diagnosis when symptoms appear, and also over-diagnosis treatment, which also is a preclinical, for example, for preclinical cancers that could have never caused symptoms nor pose a serious health threat, which involve unnecessary treatments that injure the patient. So it might be difficult for such cases. So the screening, we have to wisely choose the screening test. So Wilson and Junger in 1968, imagine it was in 1968, they have 10 criteria to enlist whether the best screening test should be or not. So the first one is when you consider for a test for screening, the condition sought should be important health problem like ours. For example, breast cancer is an important health problem. As you know, worldwide 1.7 million people per year are being diagnosed with breast cancer, and 500,000 people are being died or victimized because of breast cancer. The second is there should be unaccepted treatment for patients with recognized disease. So for us, mammography has been very vital. And the third is facilities for diagnosis and treatment should be available. So tertiary hospitals which are specialized on oncology and cancer treatment should be there. And the fourth one is there should be a recognizable latent or early symptomatic stage. So as you know, breast cancer is it elapses from stage 0 up to stage 4. So you can pick at an early stage. And the fifth one is there should be a suitable test or examination. So there might be different types of tests for considering or picking the early type of breast cancer. And the sixth one is the test should be acceptable to the population. So it shouldn't be invasive and it shouldn't be against the norm in the culture of the society. And the seventh one is the natural history of the condition, including the development from latent to declared disease, should be adequately understood. And the eighth one is there should be an agreed policy on whom to treat as patients. So the oncologists, we use a multidisciplinary team platform for such. So there should be some kind of consensus to treat such patients. And the ninth one is the cost of case finding, like including diagnosis, treatment of patients diagnosed should be economically balanced in relation to possible expenditure on medical care as a whole. So it should be as cheap as it's possible. And the tenth one is case finding should be a continuous process and not once for all projects. So you have to mind all these 10 criteria. So these two guys, wonderful guys, have discovered such kind of criteria back in 1968 Gregorian calendar. So how do you differentiate between screening and diagnostic tests? So it has been very difficult to say whether a screening is purely screening or is it diagnostic or not. So when you compare and contrast screening, so screening is in patients who are asymptomatic, and diagnostic is whether the individual has suggestive of clinical picture. And the screening is usually done or manipulated in large group, and the diagnostic one is done only in single subject. And the screening is usually less accurate, but diagnostic is a very accurate one, and the diagnostic one should be usually conclusive, and it might be also much expensive. Like there are ancillary tests, like for example in breast A, we use PET scan to diagnose distant metastasis and in lymph node involvement. And in screening it should be not basic for treatment, and in diagnostic it should be basic for treatment. So this is a nice table, as you remember from biostatics and epidemiology classes. So this is a nice table which is depicting the specificity and the sensitivity, which is also telling you the validity of the tests. And there are also other tests which are called accuracy tests, which also involves the positive predictive value and the negative predictive value. So you can see the test from here. So we have two tests. One is test positive and the other one is test negative. And there are two scenarios, whether the individuals have disease or no disease. So from the table, you can see from this one, this is called specificity, which is A over A plus C, which is those patients, those individuals with a disease who can test positive or who can test negative for the test. And there are individuals who doesn't have the disease, but who can test positively, which is a false positive, and negatively, which is true. So this is a sensitivity test. It's a nice picture, so depicting the sensitivity. So ability of the test to truly identify those who have the disease is called sensitivity. So this is the sensitivity test mainly done. So the sensitivity test is called finding the true positive, or the individual, those having the disease with a positive result, is said to be sensitivity. And usually it is done by A over A plus C. So you can see from the table, this is the sensitivity test. The specificity, the ability of the test to correctly identify those who do not really have the disease. So mainly it deals about the D or the true negative individuals. These are those individuals who doesn't have the disease and yet tests negative for the test. There are some individuals who can test positive for the disease. For example, we can take the serum PSA result. In serum PSA, for example, previously it was taught to have a value of 1 was the baseline, but eventually it was inclined to 4. So the serum PSA greater than 4 nanogram per ml was considered as a sign of prostatic CA, which increased the specificity, but it decreased the sensitivity, because it increased those patients who will have true negative results, since the number of the serum PSA level increased, but it decreased those individuals who have positive results, true positive results, which is called the sensitivity and specificity trade-off point. So when we come to the breast cancer overview, the average lifetime risk of breast cancer for a woman in the United States has been estimated at 12.3. That means 1 in 8 women. Imagine 1 in 8 women will develop breast cancer. And for 2018, the American Cancer Society estimates that 63,960 cases of female carcinoma in situ of the breast and 268,670 cases of invasive breast cancer will be diagnosed in the United States. This is in a single year. So imagine what breast cancer entails in the population. And about 41,400 diseases are estimated only for 2018. And the good news is that these rates have been falling on average of 1.8% each year over the course of 2016 through 2015. This is attributed for mammographic screening in their setup. But in our setup, as you know, mammography is not such abundant, and also in the periphery like ours, we don't have the mammography screening. We just do the clinical breast examination. Even in Addis, the number of mammography for screening is very limited. So breast screening components, breast screening is performed in women without any signs or symptoms of breast cancer. If there is any kind of signs and symptoms, it is called diagnostic rather than a screening. So that the disease can be detected as early as possible, which allows early treatment to reduce the mortality and morbidity associated with the disease. So a diagnostic breast evaluation differs from breast screening in that it is used to evaluate an existing problem. So if a patient comes to you with palpable mass and discharge from the nipple, that is just diagnostic, not screening. And the components of a breast screening evaluation are dependent on age and other factors, such as the medical and family history of the patient, and it can include also the breast awareness of the individual. Usually, patient familiarity with her breasts and also a regular clinical encounter. So you have to differentiate between self-breast examination and clinical breast examination. Self-breast examination or breast awareness is that done by the individual, and clinical breast examination, the CV, is done by the qualified physician or breast oncologist or breast surgeon. And there is breast imaging with screening mammography, and in selected cases, breast MRI. So these are the components of breast screening. The first one is breast awareness or individuals doing self-breast examination. The second one is a regular clinical encounters, which is clinical breast examination. And the third one is imaging techniques. So first, the clinical encounter. So the starting points of guidelines for screening and evaluating breast abnormalities is the clinical encounter, which includes a complete medical history followed by breast cancer risk assessment and also a clinical breast examination. The frequency of clinical encounter depends on the age and risk assessment of the patients. So in a review of controlled trials and the case controlled studies that included clinical breast examination as part of the screening modality, clinical breast examination, which will be done by the physician, which is an oncologist or breast surgeon, was found to be 54%. Imagine the sensitivity or the true positivity rate is 54%, and the specificity was 94%. So it was very specific, which shows you true negative patients were easily managed with clinical breast examination. So randomized trials comparing clinical breast examination versus no screening have not been performed yet. So we have to do such trials before judging whether clinical breast examination suffice to be screening modality or not. And rationally for recommending the clinical encounter is to maximize the earliest detection of breast cancers. So overdiagnosis and overtreatment is not a significant issue with the clinical breast examination. So as the majority of palpable cancers found on clinical breast examinations are invasive cancers. So imagine, so most of the patients come to you or come to your clinic or to your OPD once they palpate something. So before that, they won't come to your OPD or to your clinic. So clinical breast examination is an important component of a clinical encounter, and is important in order to detect early stage palpable cancers, especially those that are mammographically occult. So lobular neoplasia, you know lobular neoplasia from your undergrad teaching. So these tumors usually are mammographically occult. So it's better to do clinical breast examination in such cases. And according to the NCCN panel, inspection of the breast should be performed with the patient in both upright and supine positions. So positioning may be done so as to elicit any subtle shape or contour changes in the breast. So breast awareness. This is a broad topic, and you have to be aware as a physician, as general practitioners, as residents, you have to know about breast awareness. So women should be familiar with their breast and any changes to them. You have to ask yourself whether are you familiar with your breast or not, or are you taking your body for granted? So most of us do take our body for granted, right? So most of us don't do even the physical examinations that are recommended by the guidelines, even for us. So Data from a large randomized trial of breast self-examination screening have shown that instruction in breast self-examination has no effect on reducing breast cancer mortality. Yet, we have to do it. And in this study, 260,000 Chinese women who were not undergoing routine mammographic screening were randomized to either receive instruction in breast self-examination or not. So compliance was encouraged through feedback and reinforcement session. So they were giving them some kind of money. And yet, after 10 to 11 years of follow-up, 135 breast cancer diseases in the group that received instruction or self-breast examination, and those 131 in the control group were observed. So the cumulative breast cancer mortality rates were not significantly different between the two arms. This is a disappointing study, but mind you, self-breast examination is still important. So the number of benign breast lesions detected in the breast self-examination instruction group was higher than that detected in the control group. Imagine. So nevertheless, women should be encouraged to be aware of their breasts, since they may facilitate the detection of interval cancers between routine screenings. So this is the importance of self-breast examination. Even though it doesn't show any kind of benefit, you have to do it between screenings, because it has postulated some kind of detection during intervals. And the NCN panel recommends breast awareness, specifically that all women should be familiar with their breasts and promptly report any change to their healthcare provider. So, breast cancer risk assessment. What is breast cancer risk assessment and what does it entail? So, if the physical examination is negative in an asymptomatic woman, the next decision point is based on risk stratification. So, you have to stratify the individual or the woman or the lady at your OPD. So, once the woman is asymptomatic, once the woman doesn't have any kind of sign symptoms, so you have to stratify based on the risk factors. So women are stratified into two basic categories of risk for the purpose of screening recommendations. The first one is called average risk, and the second one is increased risk. So the increased risk category consists of 6 groups. So these women or this lady, or 1% of the cases, even the guys, are victims of breast cancer. So in the first case, women with a prior history of breast cancer or personal history of breast cancer are at an increased risk of breast cancer, and those women age 35 years of age and 5-year risk of invasive breast cancer is around 21.7% per Guile model. There are different types of model, so these are also another women with a risk factor. And the third one is women who have a lifetime risk of more than 20% based on history of lobular carcinoma in situ or atypical ductal hyperplasia. These are also at an increased risk. And the fourth one are women who have a lifetime risk of more than 20% based on family history. And the fifth one is women between the age of 10 to 30 years who took prior thoracic radiotherapy during the age of 10 to 30 years. So this is because the breast beds during those childs will be subjected to radiotherapy. So the chance of developing cancer is high. So especially 8 to 10 years after taking radiotherapy, they should be subjected to screening. And the sixth one is women with a pedigree suggestive of or known genetic predisposition. So, you know, the famous or popular people usually in US do these tests, like Angelina Jolie had done it, and also recently the father of Beyonce Knowles, the singer, is also has been diagnosed with a genetic predisposition of the breast cancer antigen 2, and Angelina Jolie and also her grandmother, her mother, used to have the BRCA1 gene. So all these 6 individuals or 6 groups are called increased risk category, or patients with increased risk. So women with prior history of breast cancer, those which have 21.7% of the per Guile model. There are different types of models or anograms. And the third one are those with lobular carcinoma in situ and atypical ductal hyperplasia. And the fourth one are those with family history. The fifth one are those who took radiotherapy to their chest during the age of 10 to 30 years. And the sixth ones are those genetically predisposed, or like Leaf-Ramani syndrome. If they have Leaf-Ramani syndrome, those who have P53 mutation, and those with BRCA mutation like BRCA1 and BRCA2 mutation. So estimating breast cancer risk per Guile model. So the Guile model includes such features. These are age, race, age at first, live birth or nulliparity, numbers of first degree relative with a history of breast cancer, age at menarche, and also number of previous breast biopsies, and also atypical hyperplasia. So this is an anogram which includes such entities and features. Then they will calculate the cumulative risk, and finally they will attribute it to breast cancer risk. So breast imaging modalities. So we use different types of breast imaging modalities. The first one is the screening mammography. Of the various imaging modalities, mammography remains the most important as it is the only one to demonstrate a mortality reduction. So the only investigation yet to show mortality reduction is mammography, and a lot of ladies and women, especially in the developed world, complain about mammography since it is minimally invasive, and yet no test has been yet shown to show the benefit of mortality reduction. And a screening mammography typically involves two X-ray images of each breast, one taken from the top craniocaudal of the breast and the other from the side mediolateral oblique. So technical aspects of the mammography can affect the quality of screening results. And the digital mammography, which has replaced film screen mammography. So, you know, we use the film screen mammography, or this one Raj የምንለው ወረቀት ማለት ነው. But currently they use the digital mammography, which show you the 3D slices. Around 40 slices will be taken, and that will be digitally reconstructed, and it showed better outcome rather than film screening, which is a 2D, only takes 2 slices of the breast, which is craniocaudal and the mediolateral. And it generates electronic image of the breast and allows for computer storage and processing of the image, thereby increasing the ability to detect subtle abnormalities. So in a study of 49,528 women who underwent both film and digital mammography, no difference was seen in the overall accuracy of the two procedures. However, digital mammography was significantly more accurate in younger women with dense breasts, and there was a non-significant trend toward improved accuracy of film mammography in women aged 65 years and older. So in women with young and with dense breasts, digital mammography or 3D constructed mammography is a better one, but in women with ages more than 65 years of age, the 2D mammography or the film mammography has shown a better outcome. In another trial of aged 45 to 69 years, randomly assigned to film or digital screening mammography, the latter procedure, or which is the digital screening mammography, showed a higher rate of cancer detection. So if we had these choices, so it's better to do digital mammography for our cases, because our cases usually they will present at a younger age, and most of them I will show you later on, more than 50% of them usually present with dense breasts. So more recently, combined use of digital mammography to two-dimensional 2D in conjunction with digitally reconstructed breast tomosynthesis improves cancer detection and reduces false positive callbacks. So they came up with an idea. Previously it was 2D. Now currently they're saying we have to do digital breast tomosynthesis, which is tomosynthesis means 3D constructed digital breast tomography. So tomosynthesis. So this is around 40 slices, as I told you before. So you will take 40 slices of the breast, and then they reconstruct them in a 3D manner. I will show you a video later on, and that will entail perfect rather than the 2D construction of only showing you 2 images. So tomosynthesis allows acquisition of 3-dimensional data using a moving X-ray and a digital detector, and these data are reconstructed using computer algorithms to generate thin sections of images, usually around 40 thin images. And the combined use of 2D and digital breast tomosynthesis results in double the radiation exposure compared with mammography alone. Yeah, as you know, when you combine the two, the radiation risk is higher. But however, this increase in radiation dose falls below those limits of radiation set by US FDA for standard mammography. So the radiation dose can be minimized by newer tomosynthesis techniques that create a synthetic 2D image, which may obviate the need for a conventional digital image. So the presence of dense breast tissue decreases the sensitivity of mammography to detect small lesions and may obscure visualization of an underlying cancer. In addition, dense breast tissue, as measured by mammography, is increasingly recognized as an important risk factor for breast cancer. So those women or those ladies who have dense breast tissue will have a higher risk of breast cancer. So about half of all women of screening age have dense breast. This is what I was saying before. So about half of all women of a screening age, which are younger, around 40 to 65 years of age, dense breast tissue referred to as heterogeneously dense or extremely dense by American College of Radiology. So the presence of dense tissue is not abnormal by itself, and it can change over time too. So the NCCN panel recommends counseling on the risks and benefits of supplemental screening for women with heterogeneously dense and extremely dense breast tissue. And different supplemental imaging modalities may be considered based on risk, patient values, and preferences. So we will see the supplemental imaging techniques that you should do or that you should add after mammography. So video on tomosynthesis, I will later show you eventually. So screening ultrasound, due to limitations of mammographic screening, especially in women with dense breasts, other imaging modalities are being explored to supplement mammography, most commonly ultrasound and MRI. So for dense breast, those women with dense breast, you have to do ultrasound and MRI. And unlike mammographic screening, both these technologies, MRI and ultrasound, lack evidence from randomized controlled trials of screening efficacy, although ultrasound is widely used in the diagnostic setting. So usually, ultrasound is preferred for those women or ladies who present with signs and symptoms of breast cancer, those who present with pain, those who present with discharge, and those who present with skin ulceration. But mammography is the best tool for screening. And most clinical ultrasound screening studies have found increased cancer detection to be incremental to screening mammograms in women with dense breast. So in women with dense breast, it's better to use ultrasound rather than mammography. However, they may increase recall in benign breast biopsies. So as I told you before, this adding ultrasound will show you the increased cancer detection, which is around the sensitivity or true positive result will increase, but the false positive result also will be increased, which decreases the specificity of the test. So, for example, a large prospective study in women with dense breasts and elevated risk for breast cancer found that adding screening ultrasound to mammography identified an additional 4.3 cancers per 1,000 women screened. Almost 4 individuals were added out of 1,000 women, but it increased the number of false positive results, which increases the anxiety, which increases examination rate and also investigation rate. So subsequent follow-up studies showed similar results. However, in women with dense breasts, the mammography sensitivity was found to be only 50%. And the sensitivity of mammography plus ultrasound was 77.5%. So when you face a woman with dense breast tissue based on mammography, you have to add ultrasound. This will increase the sensitivity to 77.5. Application of screening ultrasound to women with dense breasts in clinical population has produced the similar results. So although there is increasing evidence that breast ultrasonography or ultrasound can be useful in the incremental detection of breast cancer as an adjunct to screening mammography in the evaluation of women with dense breast, the routine use of ultrasound as a universal supplemental screening test in women with average risk is not recommended. So unless it is a woman with an increased risk, you don't have to do ultrasound left and right. Ultrasonography is commonly used for diagnostic follow-up of an abnormality seen on screening mammography. So if a patient or a woman present to you with a lump or a pain or some kind of lesion, you have to do breast ultrasound. So screening MRI, the sensitivity of contrast-enhanced breast MRI at detecting breast cancer is higher than the sensitivity of mammography, although the specificity of the former procedure is often lower. So when you do breast MRI for such cases, you will have a higher sensitivity, or you will pick true positive patients, a lot of true positive patients, but it will also increase the results of the false positive ones and resulting in a higher rate of false positive findings. In addition, microcalcifications are not detectable with MRI. So MRI lacks the feature for detecting microcalcification. Similar to screening ultrasound, whether MRI screening impacts survival has not been addressed in randomized clinical trials. So whether doing breast ultrasound or breast MRI is an adjunct rather than the best modality for screening. So still, we are yet residing on mammography to better it. Therefore, careful patient selection for additional screening with MRI is needed. So although current evidence does not support the use of breast MRI to screen women at age risk of breast cancer, the benefits of screening MRI for early detection of breast cancer in women with high risk, such as those. So you have to select patients for MRI. These are aged 10 to 30 years with a prior history of prior thoracic radiation. So those individuals who took radiotherapy to the chest, especially women who took for lymphoma patients like Hodgkin lymphoma, it is called mantle radiation. During the age of 10 to 30 years, they will have their breast beds, which is susceptible for developing breast CA. So this should be screened with breast MRI since it has a high sensitivity and a known genetic predisposition for breast cancer. As I told you before, those with BRCA1, BRCA2 mutation and P53 mutation, and also a strong family history of the disease, especially the first degree relatives, the mother, the daughter, and second degree relatives, usually the aunts. You have to ask them carefully. And the American Cancer Society has published guidelines recommending the use of breast MRI as an adjunct to screening mammography in certain population of women at high risk of breast cancer, rather than the main one. So nevertheless, a high false positive rate for screening MRI was identified in several studies. So this is the difficulty with screening with MRI. So studies have reported that the deposits of gadolinium, a component of MRI contrast agent, remained in the breast of some patients who undergone 4 or more contrast MRI scans long after the last administration. So retention of gadolinium has also been seen in the bone. So it might be retained in the bone and also in the brain, this gadolinium contrast. And the clinical significance and practice implications of these observations are unclear and are being investigated. So they were shocked in 2015, the FDA was trying to investigate such cases, and but in 2017 the FDA issued an update stating that its review of available data and it didn't identify any adverse sales effects from gadolinium. So criteria for the performance and interpretation of high quality breast MRI include a dedicated breast coil. So even having just an MRI doesn't help for screening with breast MRI. So they need to have a breast coil, and radiologists experienced in breast MRI, and also the ability to perform MRI guided needle sampling and also wire localization of MRI detected findings. Since MRI is subjected to having a lot of false positive results, these individuals should be experts on MRI. In other breast imaging modalities, they are currently being studied. So there is emerging evidence that breast scintigraphy, contrast enhanced mammography may improve detection of early breast cancers among women with mammographically dense breasts. So even they are trying to better the mammography with contrast enhanced mammography, but current evidence does not support their routine use as alternative screening procedures. So this is our National Comprehensive Cancer Network guideline. This is a US institution, so we use their guideline left and right. So this is a current one, much updated. It was also published on June 2022, almost 3 months back. So a screening or symptom category. So clinical encounter, for example, in your OPD, you might face those patients who are asymptomatic. They will come with an average risk, or they don't have any kind of increased risk. So if their age is between 25 and 40, you just have to do clinical encounter or clinical breast examination every 1 to 3 years. And you can give breast awareness, which is self-breast examination, which will be done in their home. And if their age is greater than 40 years of age, you have to do annual clinical encounters, which is also clinical breast examination by the physician, and also annual screening mammogram should be done. And it is said to be category 1 recommendation. So for those with average risk, asymptomatic patients with the age greater than 40 years of age, the category 1 recommendation is doing mammogram. So NCCN recommends you to do mammogram every 1 year for those patients above the age of 40 years of age. And tomosynthesis is recommended if available. So as I told you, 3D constructed mammography, if available, it can be done. And breast awareness is also another entity that can be done. And increased risk, those with increased risk like residual lifetime risk, more than 20%, having like family history and also thoracic radiotherapy between the age of 10 to 30 years, and also those individuals with Gail model of more than 1.7%, atypical ductal hyperplasia, lobular neoplasia, these have increased risk. So these have their own kind of follow-up, I will show you. And there are pedigrees or family history, like first degree relatives, like the mother, the sister, and the daughter. If they are having an increased risk, I will show you how you follow up. And the symptomatic patients who present with symptoms, it has its own follow-up rather than screening. So increased risk individuals or ladies or women who came with family history or who came after thoracic radiotherapy 8 to 10 years later, you have to do clinical encounters every 6 to 12 months or clinical breast examination. And also you have to do consider referral to genetic counselor or genetic testing should be done, and also consider referral to a breast specialist as appropriate. In their setup, there is breast oncologist and breast surgeon after endocrine surgery. And you have to do also annual screening mammogram. Tomosynthesis is also recommended to begin 10 years prior when the youngest family member was diagnosed. So if there is a family history, you have to start mammography 10 years earlier before the younger individual in the home. And also annual breast MRI also should be done for such individuals. This is also another recommendation as an adjunct for increased risk individuals. You can do annual breast MRI, annual screening mammograph, clinical breast examination every 6 to 12 months, and also consider risk reduction strategies. And for those who took radiotherapy, you have to do annual clinical encounters or clinical breast examination, usually 8 years after radiotherapy, and also self-breast examination should be given for them. And also current age, if it is greater than 25 years or older, you have to do those annual screening mammograms, annual breast MRI, and also screening with clinical breast examination 6 to 12 months. The per Gale model also, those individuals who have more than 1.7% risk, you have to do also clinical encounters and also annual screening mammogram, and also risk reduction strategies and breast awareness. And those individuals who presented to you with ADH or atypical ductal hyperplasia and lobular neoplasia, their lifetime risk is more than 20%. So you have to screen them with mammogram, annual breast MRI, risk reduction strategies also should be given, and breast awareness should be given. So these are individuals which I showed you earlier with increased risk for breast cancer. So if there is palpable symptoms, there are ladies or individuals who come to you with signs symptoms of breast cancer. So if the age is greater than 30 years, you have to do the diagnostic mammogram or ultrasound, not screening mammogram. It should be diagnostic mammogram and ultrasound, and you have to do both. You can see the plus sign, so you have to do both. So based on their BIRAD score, you can continue with the treatment. So BIRAD category 1 is negative, BIRAD category 2 is benign, and BIRAD category 3 is said to be probably benign. Once these are diagnosed, BIRAD category 4 and BIRAD category 5, you have to do core needle biopsy. But when the age is less than 30 years, you have to depend on your clinical correlation, and you have to subject individually. So you have to do ultrasound most probably. So based on your ultrasound result, you can concur whether it is BIRAD score is the above one or the later ones. And if low clinical suspicion, you have to observe them at least for 1 to 2 menstrual cycles. And if the symptom persists, you have to do again the ultrasound, and you have to see the BIRAD score. If the BIRAD score category 1 to 2, which is category 1 is negative and category 2 is benign. So if palpable symptom correlate with imaging finding, you just follow the screening and you do annual screening. And if it is BIRAD score is category 3, this is a cutoff point or the middle ground. If low clinical suspicion, you just have to do physical examination and imaging with ultrasound and diagnostic mammogram for 2 years, every 6 to 12 months. So stable or decrease in size, just screening every year as an average individual. But significant increase in size and clinical suspicion, you have to do core needle biopsy. But if clinically suspicious, you have to do core needle biopsy or aspiration or FNAC should be done. So breast cancer screening and diagnosis, breast screening considerations are individuals should undergo breast cancer risk assessment by age 25 years and be counseled regarding potential benefits, risk, limitations of breast screening in the context of their risk stratification, and shared decision making is encouraged based on the patient values and preferences. So how many of you from the ladies or from the women have discussed such cases with your patients? Because once the age of 25 years is reached, the cutoff point is said to be 25, especially for self-breast examination and self-breast awareness. And the age of 40 years, based on NCCN guideline, is said to be designated for routine screening with mammography. So consider severe comorbid conditions limiting life expectancy, especially if the individual or your patient who comes to your OPD come with severe disease like CHF and other disease, the need for breast cancer screening is not that much. So you don't have to do the screening. But if the life expectancy is more than 10 years, that might be subjected to screening. Upper age limit for mammographic screening is not yet established. So the mammography can be done usually up to 70 years of age. Some of them say up to 80 years of age, yearly or biennial, every 2 yearly can be done. So for age over 75 years, screening recommendations are considered on individual basis. So you have to do risk stratification, and you have to see your clinical examination, your medical history, your physical examination will lead to whether to do screening or not. It is critical for the location of physical findings from clinical breast examination to be documented. So as cloak or quadrant location. So you have to specify which quadrant and which from the cloak wise allocation, which cloak is affected. And distance from nipple facilitates geographic correlation with imaging findings. So multiple studies show that tomosynthesis can decrease callback rates. So once you do mammography wouldn't show you the exact position of the tumor. So clinical breast examination and mammography should be done. So even doing mammography won't help. Sometimes callback will be there, and you will call back that patient after some months or a year to see the difference. But nowadays, tomosynthesis have shown the 40 slice or the 40 images are helping to diagnose a patient easily. So this is Angelina Jolie. You know Angelina Jolie. Her mother was diagnosed with breast and ovarian cancer, hereditary breast ovarian cancer syndrome, and her grandmother also was diagnosed with breast cancer. So she did a test which is called the breast cancer antigen test, and Angelina Jolie decided, she was diagnosed with BRCA1 gene. So Angelina Jolie decided to make a preventive double mastectomy in order to prevent or to reduce a chance of developing breast cancer. She did both bilateral mastectomy and also bilateral oophorectomy. So she inherited the mutated BRCA1 gene from her mother. That's why she did the surgery. So she said, I did not feel any less of a woman. I feel empowered that I made a strong choice that in no way diminishes my femininity. So after her, it is called the Angelina effect. And a lot of famous women and ladies are being diagnosed with breast cancer, and they are sharing their stories so that they are trying to create awareness for the mass or for the population. And you can check Wanda Sykes. So many actresses are being diagnosed with breast cancer. Even guys, black actors, they are being diagnosed with breast cancer. So breast cancer consideration for MRI, recommended annual MRI screening for such individuals is recommended. For individuals with a genetic mutation, as I said, BRCA1 or BRCA2 gene, and also those with Li-Fraumeni syndrome with having a P53 mutation. For individuals who received radiotherapy between the age of 10 to 30 years, so these are also at an increased risk. And for individuals with a lifetime residual risk of more than 20% per Gale model and so on, or family history. And consider annual MRI screening for individuals with atypical ductal hyperplasia and lobular hyperplasia. So we usually say either we do the excision or we just allow them to go, but you have to do MRI screening. And insufficient evidence to recommend for or against routine population-based MRI screening. This might be insufficient recommendations, but you can do. If the residual lifetime risk is 15 to 20%, you can do the MRI. Heterogeneously or extremely dense breast also on mammography. You might face individuals or women or ladies with dense breast, so you might subject them with MRI, but it is recommended against MRI if it is the risk is less than 50%. So there are anograms. These are risks which are done after cumulative risk is added and so on. So ionizing radiation during pregnancy, avoid ionizing radiation during pregnancy. It is frequently on the minds of both individuals and their providers. So it should be reassuring to them that mammography result is extremely low fetal ionizing radiation dose, substantially below the worrisome thresholds for harm. So you can screen any pregnant mother with mammography. The general accepted minimum threshold for inducing fetal teratogenic effect is 50 milligram, but the measured fetal radiation dose from a 4-view mammogram is only less than 0.03 milligram, which is a magnitude of difference approximately 1,600-fold. While there are no specific studies evaluating the sensitivity and specificity of digital breast tomosynthesis compared to digital mammography in pregnancy, the improved efficacy of digital breast tomosynthesis in dense breast tissue in non-pregnant individuals may make the modality particularly useful. So if you have a digital breast tomosynthesis, you can use it also for pregnant individuals. While there may be a small increase in ionizing radiation delivery with tomosynthesis compared to mammography, this small increase should not have any expected effect on fetal safety. So this is management of breast cancer screening and breast symptoms during pregnancy. So the average risk individuals, usually we recommend to do mammography. The clinical breast examination and mammography are recommended. Ultrasound not recommended, MRI is not recommended. There is no contraindication to screening mammography during pregnancy. And the ionizing radiation is very low. So there are no data evaluating the use of ultrasound alone as an alternative screening method in average risk individuals. So in increased risk individuals also, you have to do clinical breast examination and also mammography. Ultrasound is optional, but MRI is not recommended for pregnant individuals. So individuals who receive thoracic radiotherapy between 8 to, as I told you before, these are the increased risk patients. So you have to do mammography and clinical breast examination, and ultrasound is optional based on your results of mammography. So imaging in lactating individuals, nursing or breast pumping prior to mammography may improve sensitivity by decreasing the density of the breast parenchyma because the lobules will have milk in them. And mammography is always appropriate in individuals who are lactating, who have an indication. That means there are no contraindications to mammography in individuals who are lactating. So you can do mammography for lactating individuals also. There is no contraindication to routine screening mammography in individuals when lactating. Breast MRI in pregnancy and lactation. The use of contrast-enhanced breast MRI during pregnancy is contraindicated because gadolinium in all forms crosses the placenta and enters the fetal circulation. So you can't use MRI in pregnant individuals. There are concerns that the gadolinium ion may then dissociate in the fetal circulation and cause toxicity of the fetus. The exact frequency of this occurring and the associated impact of dissociating gadolinium on fetal toxicity is uncertain, but there are no reliable data on fetal safety of gadolinium exposure during pregnancy. So therefore, gadolinium administered with breast MRI is best avoided during pregnancy, and other modes of breast imaging should be used like mammography and ultrasound. Fortunately, there is a minimal excretion of gadolinium into human breast milk, which is less than 1% of permitted neonatal dose of contrast over the first 24 hours of after maternal administration. So breast MRI appears to be highly sensitive for detection of known pregnancy associated breast cancer. So although there appears to be lower specificity for breast MRI, higher false positivity norm in individuals who undergo breast MRI while lactating. So in lactating women, you have to use breast MRI preferably, especially who has increased risk like patients who breast MRI because it is highly sensitive for detection of pregnancy associated breast cancer. If individuals undergo breast MRI due to the minimal contrast excretion into breast milk, individuals are not required to pump and discard breast milk after administration. So every time when you do the screenings, whether it is mammography or breast MRI, the individual should do the pumping before the imaging rather than after the imaging. So these are some of the recommendations during lactation. Average risk individuals during lactation, clinical breast examination and mammography is recommended, ultrasound not recommended, MRI not recommended. But for those increased risk individuals, you have to do clinical breast examination, mammography, and also breast MRI helps a lot. So you have to know the difference. So this is a slide that shows you the different types of the BIRAD score, which is a breast imaging and data system. So you have to reporting breast imaging, reporting and the data system. This is a category 0 needed additional imaging evaluation. So if a radiologist diagnosed the case as BIRAD category 0, so there should be an additional imaging. Diagnostic workup, including comparison to prior mammograms and diagnostic mammogram and or ultrasound is indicated to do. But if it is BIRAD category 1, it's said to be negative and only screening annually should be done. BIRAD category 2, the same, screening annually should be done. BIRAD category 3, this is the middle ground. So you have to do ultrasound and mammogram for the first 24 months or for the first 2 years with frequent visiting. If it is stable after 2 years, screening can be continued. But if there is increased suspicion, you have to do core needle biopsy. BIRAD 4 and BIRAD 5, you have to do image guided core-needle biopsies it's said to be stereotactic or 3D image guided. If any sort of biopsy should be done, viral category is proven malignancy. It is usually the mammography is done after the biopsy. So this is a mammography image, and this is the tomosynthesis. You can see the 3D reconstruction. This is the patient being the tomosynthesis being done, and you can see the different types of images from here, around 40 slices. So finally, I would like to say I am a member of the Ethiopia Cancer Association or Ethiopia Cancer Mahaber, which helps around 16 women with breast cancer, cervical cancer. It is around Black Line School, Churchill Street, and you can help just texting okay with $1 per day with 9565. So please help them. They come from different parts of the country, and they are very poor. And the NGO is established by physicians, oncologists, and volunteers, and also patients who survived the disease. And if you see them and visit them, you really feel a lot for them. So the first question is, what is the difference between digital mammography and tomosynthesis? So digital mammography versus film mammography just simply means that usually we do it in our setups also using a CD. So usually they try to take the image digitally and they can try to reconstruct it. But tomosynthesis means that even the image is being taken by taken with another arm which circulates around the breast, so that it will reconstruct it digitally with a software, so that you will have a 3D feature rather than constructing a 2D image just based on taking 2D images. That's the difference. Okay, the third one is, why is mammography isn't recommended at the age of 20s to 30s, and how to deal with these patients with high risk of BRCA regarding mammography? So for those age to 20 to 30, first of all, such kind of individuals have low risk, which is called average risk individuals or average risk women. And mammography has its own also risks because it uses X-ray imaging. So we don't like to subject them to X-rays, just to screen them. And when dealing with BRCA mutation patients, it's usually is based on the physical examination, the history, and also taking mammography and ultrasound. Also, you can add the breast MRI. And rather than doing such investigations illustriously, you can do also genetic counseling for cases having or family history. So that based on that, you will decide your treatment, and your investigation will entail the diagnosis. And the other one is, what about male breast CA screening? So there is no any consensus guideline on male breast cancer screening. And usually if those individuals having a male breast CA or a family history of either personal history or family history of male breast CA, you can do mammography. As you know, the male breast tissue is very small and usually doesn't have the lobular component, so mammography might be difficult for such cases. But in individuals having especially the breast cancer antigen 2, you have to do mammography to screen such cases. Even an example, as I told you before, Beyonce Knowles' father has been diagnosed with BRCA2 gene, and it was diagnosed based on mammography. And the other one is, as we know, only less than 20 mammos in Ethiopia. Do we better do ultrasound in this case? So that's the difficulty. As I told you before, it didn't, both MRI and ultrasound, they are adjuncts rather than showing any decrement in mortality. And doing ultrasound is more preferred for such cases presenting with signs symptoms of breast CA. So those having breast pain, breast mass, skin lesions, and different. And ultrasound also helps you to differentiate between benign cases and malignant cases. But in their setup, they are having tomosynthesis, which is very ideal screening test. So it's better to do mammography if it's possible. If it's not, You can correlate clinically that we do left and right in our setup. We don't have it here, even in eastern part of Ethiopia. We don't have one mammography machine, so we are using just breast ultrasound and also our clinical judgments and also clinical breast examination to judge our patients' screening or evaluation. So the other one is anonymous attendee, 20-year-old female patient with multiple breast months of 1 year duration, recently developed tenderness on palpation and also progressive increase in size. Recent ultrasound, multiple heterogeneous hypoechoic well-defined masses with large measure 3/2 and BIRAD is 3 likely. Fibroadenoma, FNAC shows single cell with mild nuclear atypia and conspicuous nucleoli. Stage 1 AC by Yokoma diagnostic category suggestive of thyroid tumor. How shall we proceed from here? So I think this is more of not screening, this is more of treatment. So based on the stage and also you have the FNAC and the score is usually BIRAD 3. So in our setup, even though this is a smaller size, we do the MRM, but in their setup, they do lumpectomy and the size is very small, so you can do, and it's also called mainly suggestive of thyroid tumor. So you can do also tomosynthesis for such cases. It might be very difficult to diagnose whether this is an invasive carcinoma or not. So additional tests should be done for her, but I prefer the multidisciplinary team discussion for such cases because the FNAC suggests other thing and the ultrasound suggests other things. So additional supplemental imaging techniques and also discussing with the pathologist will better localize and diagnose the case. So you have to bring this case for multidisciplinary team discussion and we can treat after that. How breast screening during menses? As I told you before, there is no any difference for having menses or not. So you can do your mammography based on the result. And the clinical breast examination, usually you have to do it 3 to 5 days after menses because menses by itself might cause some breast pain and also swelling. And when do we advise women self-breast examination? So currently there is no recommendation, but as I told you before, for average risk individuals, more after the age of 25 years, you have to do self-breast examination. As you said, lobular carcinoma is hidden on mammogram. What is the best screening tool? As I told you before, there is no any best screening tool except mammogram, but you can add based on your clinical judgment and physical examination and your medical history, other adjunct investigations like breast MRI or ultrasound based on the individual risk assessment or risk stratification. Women with breast cancer and severe disease, likely kidney failure, how to treat? Women with breast cancer and severe disease like kidney. So it will depend on the stage of the breast cancer and also the prognosis of the case. After that, we can treat her, no problem. We have to see the stage and also the prognosis of the patient. But if the kidney failure is in the stage renal failure, that's another thing. But there are different options of treatment, like hormonal treatment, for example. So it depends on the clinical examination and the clinical stage of the disease. You said radiotherapy is a risk factor. What about repeated X-rays and CT scans of the chest? If they increase the risk by how much? Yeah, they have their own risk factor, but mind you, we are talking about when you say radiotherapy, we use mega voltage energy. But when you use CT scans and X-rays, we use just kilo voltage energy. So there is a huge difference between radiotherapy and the diagnostic modality. So the risk is not that much, but repeated imaging like chest X-ray and the CT scans are not recommended for such cases. It should depend on the patient's scenario, or you have to individualize it based on the case. In individuals with dense breast tissue, should we go for mammography, then ultrasound, or ultrasound from outset? So you can't know whether the breast tissue is dense or not. So usually a combination of mammography and ultrasound will be done after the mammography. Male breast cancer, I think I have discussed it. Thank you, doctor. How do we apply screening techniques and pathways seen on guideline in our country, and especially early detection and education to avoid late metastatic cancer? So currently we are working with the Harari Health Bureau, for example, in our periphery center in Harar. Harama University, and we are talking with Clinton Health Initiative also to discuss on mass screening based on clinical breast examination. We don't have mammography, so awareness should be created with mainstream media, social media. We are doing that, even using hacking page and different media platforms. So based on those, we can create that kind of awareness and also do clinical breast examination, at least to screen such cases. Otherwise, in a setup where you don't have mammography or adjunct breast MRI, it's very difficult to screen them all. But in their setup, they do usually such cases. In October month is, as you know, breast cancer awareness month, they do a lot of screening. Does PET scan or positron emitting tomography scan have any feature in detecting more active mitosis? So PET scan, usually it has its own indication based on the stage of the disease for breast cancer. So we don't do it left and right. Usually we do it after stage 3, and usually it will show us we use the 18-APDG glucose contrast, and usually it will be better to do after stage 3. And there are different types of PET scan also for breast patient. And can mammography be used for any other pathology other than CA? Yeah, it can be used. So it's mainly for diagnosis. So you can use it for other diagnosis too, or rule out whether it's a benign or not. Is it contraindicated to take a mammography screening at age below 25, and why? So you don't have to do mammography. As I told you before, usually younger breasts are dense breast tissue, and usually also younger individuals are when subject them with X-ray, which is around kilovolts. So we don't expect them to have breast cancer also by this age. So at least, as you know, carcinogenesis, it will take more than 10 years to reach that invasive cancer. So usually we don't concern ourselves for screening such younger people, but if they have family history and other increased risk, we do the mammography or other tests also. Anonymous attendee, how breast cancer is detected in men? It is stated in the presentation that in America are vulnerable. Yeah, so we do mammography, we do physical examination, we do history, and a lot has been discussed. So mainly mammography will be used. Even in some cases, we can do also breast MRI. What is the current need of the epidemiological research attention in the effort to reduce mortality and morbidity from breast cancer? So there are a lot of research, and there is different guidelines, around 7 guidelines. I only used National Comprehensive Cancer Network, which we use in Black Line, and also in our setups, especially in Ethiopia, we use the National Comprehensive Cancer Network, and that has been our guideline. But in the US, if you go there, American Cancer Society has its own recommendation. Different guidelines have their own recommendation based on their research and so on. Which breast screening in setting where mammography is not available? So clinical breast examination with breast ultrasound is the preferred one. Breast cancer is also a disease of male. Is the screening method also applied for male? Yeah, there is no any consensus recommendation for male breast A, but if there is a high risk, we do mammography, and physical examination, clinical breast examination is the best. And the other one is, what about Ethiopian breast cancer guideline about contraindication with Ethiopian public health concern? So there is no any breast cancer guideline yet. So there is, I know the Ministry of Health have come up with a guideline for cancer in general, but yet to be defined based on our research or based on any recommendation. So we have to discuss with the ministry before suggesting anything. Any association between breast reconstruction surgery, likely plastic, and the risk of breast C? So we don't recommend, or we don't say this yet, because we have to be ideological, and we have to see the result of such cases. As you know, breast reconstruction surgery is just a new thing within the past decade, and so we have to see. And for ourselves, first we have to see the result of such reconstruction after some while before deciding whether it is a risk or not. When is the appropriate day to do such breast examination? It's a nice question. So after menses, 3 to 5 days, that's the best day. What about FNA? Is it accurate? Can we be sure about sensitivity? So the best in their setup is category 1 recommendation is said to be stereotactic biopsy or core needle biopsy is a preferred one, image guided. In our setup, we don't have it here, so we use FNAC. So the prevalence and distribution of breast cancer in Ethiopia. So breast cancer is said to be the first one, which is around only it was done in Addis Ababa Cancer Registry in Addis Ababa Tukur Ambassa Hospital, and it showed around 32.5%, which is around so one third of the breast, one third of the cancer in general. So its number is very high. Is mammography or ultrasound is mandatory to be screened for breast CA after a diagnosis of benign breast lesion at left breast by microscopic? This is my scenario. Please give me my recommendation. So if anything, any suggestive thing for breast cancer, there should be a regular screening. As I told you before, mammography, ultrasound should be added, and the risk stratification based on the clinical symptoms, the history, and physical examination will dictate the follow-up of such cases, and it's better to follow them. Is prophylactic mastectomy done for those with BRCA in Ethiopia? We don't do it here really, and we don't have the genetic counselors and the genetic testing, even testing for family pedigree. So it's very difficult to do the surgery. I had a patient with her mother and grandmother diagnosed with breast cancer at Black Lion when I was an R1 resident, and we only did the genetic counseling with our seniors, and finally the test was tested abroad, and yet the individual couldn't afford such treatment. So there are, after the surgery, as you know, you will do bilateral mastectomy and bilateral oophorectomy. Imagine as a result of such invasive surgery. So there should be some kind of patches, hormonal patches, and other things to support the lady to feel like her or feel like a woman. So they are very difficult surgeries. Thank you.
All right. Thank you so much, doctor, for giving such a long time for the question and answer. One last thing. So if you have any message or last remarks that you have, I think it's breast cancer month also. So regarding that or regarding the topic, if you have any last message for our participants, I'll give you the chance.
Okay, thank you. So I would like to say, please, most of us are here health professionals and general practitioners. So we have to do our part to awaken our society, our community about breast cancer. And we are seeing the case left and right. Even in our center, around 40% of the cases from, we have collected 1,000 charts from Hiotfan Hospital at Armenia University, which resides in Harar. And after out of 1,000 charts, around 400 was 400 were breast cancer patients, and this show you the prevalence of the disease, and it's very high. And the patient usually came with a stage 3 and stage 4, and which is very በጣም ነው የሚያሳዝነው እና we have to do our parts to enlighten our community and our society about breast cancer, cervical cancer, and please do the awareness, especially use this month, October month, to create the awareness. And finally, please be the member of this association. This was established by our teachers, Dr. Matthews, Dr. Bogale, which are subspecialists, internists, which learned clinical oncology later on in their life. So they are very awesome, and there are also volunteers which are very dedicated to the cause of such. And also there are patients who are survivors of breast cancer, cervical cancer, who participate in such cases every year. So please help them. Just SMS saying okay, and only one number will be given to the association. And also you can visit them in person. It is in front of Black Lion School at Churchill Street or Churchill Godana. So you can go there and visit them. They came from different regions of the Ethiopia, and they are so different people with different diagnoses, with esophageal CA, cervical CA, breast CA. They help around 16 patients. They feed them, they clean them, they give them sanitary pads, they give them beds, different types of help what they can. So please help them and do your part. And thank you, Blue Health Ethiopia, for giving me this chance. And thank you, everyone.